The, uh, the topic which myself and also Steve Chu, my partner who will follow me, we kind of do a little bit joint, but it's two separate topics, but you'll see how easily they lead into each other, is the concept of immediate socket placement. Predictable, the word predictable is interesting, isn't it? Because the word predictable is there because can we call it predictable? If I fell off this ledge right now and I fractured my tooth and I walked into your office, can you predictably replace my tooth that's fractured and say that the tissue is going to be right shape and it's going to look great? Because you say no problem. I'm going to put the implant in. Think of all the variables. If you take a tooth out, immediately today, and what patient's going to ask you, how much does it cost? How much am I going to get hurt? Can I go to work and all that? But then what are they going to ask you? Will it look the same way, especially if they have high smile line, right? Makes sense. And you say, will it look just like my old tooth? My old tooth was perfect. I just fell and I broke it, but I love my old tooth. Can you make it look just like my old tooth? And you say, well, you start to hedge a little, right? Well, everybody's a little different. Do these words sound familiar? It depends on how you clean it, how you heal. I can't be sure. Does those words sound a little familiar to you? Yeah. True? Of course it's true, because you can't guarantee how somebody's going to heal. But you can come close. And what we're going to show you today is that with modification of some basic principles of things that we've been doing, we really can come close to this. Now, look at all the variables with immediate socket placement. How do you take the tooth out is number one. That sounds so stupid, doesn't it? How do you take a tooth out? Well, we're going to get to that a little bit today, just for a few minutes, because it's a must. It's going to be the major difference between what you see in the literature versus what we're going to show you today. Just how you take the tooth out. Yeah. Then you put the implant in. Think about what implant do you choose? What kind of design? Should it be tapered? Should it be not? Should it be platform switch? Should it be not? Should it be internal versus external? Does that make a difference? Should it be wide? Should it be narrow body? Should I put it towards the buccal? Should I put it in the middle? Should I put it towards the palate? If I have a gap, because the size of the implant is smaller than the socket, should I put a graft in? If I put a graft in, what kind of graft should I do? Should it be removable? Should it be resorbable? Should it be non-resorbable? Should I cover it? Should I do primary coverage? Should I put a membrane in? Should I put a connective tissue graft in? There are no variables at all, are there? Do we have something to talk about today? Do we have something to talk about today? You bet. Now, you've seen all kinds of great people up here. These are the best in the world. These people that they brought in here are just incredible. And they've shown you, of course, great successes. The question is predictability. Predictability. Can we get something as a standardized procedure? And as you will see, we'll show you a standardized procedure that we've grown to accept as being extremely predictable, and we're going to give you some numbers. With a multi-center study, before I finish today, we'll give you numbers to verify this. Not just, I'll show you one good case and everybody will be happy maybe. Oh, look how nice the case is. That's not the way we do things. Okay, so let's go. Are you ready? I want to give credit to my great group. Of course, Steve is going to follow me. As you know, Steve, of course, Steve Chu. Where'd he go? Did he go? He's up there somewhere. There he is. And so Steve has been great to have as a partner, and these are my other partners, and all periodontists, prosthodontists, or orthodontists. So we really have, similar to what Goldstein, Garber, and Salamer have down in Atlanta. We have a similar type of team. And I love going to work on the 2 days a week when I'm in the office. The other days I'm at Columbia or on the road teaching. Let's go. So let's do first a little background. Then we're going to talk about this whole concept of what happens to the buccal shape of a ridge when you take a tooth out. What do we know and what we don't know? And then we'll talk a little bit about where we then have to go for the future, because we don't have all the answers, but we're getting close, as you will see. So let's take a look. First in background. This is the classic thing we see all over the place. Patient comes into our office and is complaining about recession on the mid-tooth and the color. So Steve will talk about the color and transparency of tissue. We'll have a whole discussion of that and some new research on that. But the transparency, you see the darkness up there, plus the recession is obvious to the patient. So you got the recession combined with the color. So over 60% of my new cases today in our office, in my private office, are redo of other people's work. That's not a great statement to make. Now granted, we're known for this kind of thing and repairing, but this is tough stuff. This is some of the most difficult things to do. I'd rather do it right the first time than try to repair this, especially if it's rather recent and people just went through finances and so on. So let's take a look at what I came up with this socket definition in the year 2000. 13 years ago. Now, Garber and Salamer have also a very good one with interdental parts included, and this is just simplified an extraction socket. What do we have? And it's related to the buccal plate being present or not. So what you see here is the type 1 defect is where the buccal plate is present and the soft tissue is present. Everything's ideal. Everything's there. And what you're going to see us focus on is if it's there, I want you to leave it there. Simple rule. Number 2, type 2 defect is where people get into trouble. People get into trouble because it looks like a type 1, especially when the tooth is in there. It's still being supported. The tissue is still being supported. And it looks the same, but it's not. So today I'm not going to focus on 2, but I'm going to certainly focus on 1. What do we have? The key is first to differentiate between the 2 and not to do type 2 defects with immediates, not in the aesthetic zone by any means. You build that bone up, do the tissue work, and that's multiple ways to do it, as you've seen in these papers that everybody's shown you, and then come back and place the implant. This is the one this is a perfect place to call it a crapshoot. We're in Vegas. This is rolling the dice, because sometimes you'll be great with this. Everybody will show the results when you put the implant in, you put a graft in, you put a membrane in, and everything went great. And those are the ones you see on the lecture circuit. But 1 out of 10 may not look so good. It's not on the lecture circuit, but it's in your office. You all have that where you got the implant locked in because you have apical bone to lock into. So there's no question that the implant's going to lock in 98% of the time. What's the problem? It did lock in, and you still got recession. Those are the ones that you really, that's the patient you don't want to see on your roster every day, on that day, because you know that that's going to be a problem patient. Because then the implant's exposed now. If you get recession, the implant's exposed to saliva. It's no longer clean. It's not an easy graft. It's not a predictable graft. And who's going to pay for that? You didn't tell the patient they were going to have anything but 1 graft. Now you have to go back in, try to clean the implant, which is almost impossible, and try to get bone to reconnect to a dirty surface now, not a sterile surface. Totally different. Type 3, nobody gets into trouble with. They build it up first. Bone and soft tissue are missing. So let's focus on the type 1 socket, because that's really the focus of what we can learn from this. The first thing is what? Know that you should only be doing immediates of type 1 socket. Number 2, there are 3 sources of blood supply, of course, to this buccal plate. The ligament, the periosteum, and the marrow. Now the ligament is gone because you just took the tooth out. And the ligament is very vascular. Even though on diagrams it looks like just a bunch of fibrous tissue, the ligament is extremely vascular. And people don't realize how that's why we can adapt to occlusion every day of our lives. So there's about 20% of the ligament is vessels. So you're taking away a huge amount of blood supply to this thin piece of bone. Now, here's the key. Are you ready? If you open a flap, what have you just done? You've severed blood supply number 2. You say, but then, look, here's my pictures. I put it right back. It's beautiful. I covered it up, huh? Great. I always say to somebody, give me your finger. I'm going to cut it off right now, but I'm going to put it right back. Does that make you happy? That's what you've just done. You've cut the blood supply to that buccal plate. And it just doesn't reanastomose in 1 second. Even though you covered it, you don't see it. But what's happened? It's going to take, 4 to 6 days to reanastomose the blood vessels through the clot now. And what's left during that 4 to 6 days? The marrow, standing on its own, endogenous blood supply. But it's so thin, the question is, how thick is this buccal plate? How thin is this and how thick it is? So I know this is a very personal question. I know we're in Vegas and, you're trying to come up with a good line. You go into a bar, a guy walks into a bar and says, hey, how thick is your buccal plate? Now, you either had a very interesting night or you got slapped. I don't know. This is the kind of thing how thick is your buccal plate? Yours, you sitting here right now. You know it's thin, but how thin is it? Look at the numbers. We just recently saw this article. It hurt to read it because they opened the flaps to do the data. So it was very good researchers, Mariano Sanz and his group in Spain and, of course, to Europe. And they opened 72 cases. And they opened the buccal plate, and after an extraction, they opened the tissue to examine how thick this buccal plate is 1 millimeter up. The good news, they at least got measurements. I hope they never do this again. And you should never do this again. This is a no-no. Because they opened the flap, and then they measured this. Now, what distance was this? Look carefully. 64%, 2/3 had only 0.5 millimeters of thickness. Are we in trouble? We're in trouble. Look at this. And another 23% had 1 millimeter. So 90% of the buccal plates was 1 millimeter or less, and most of them were 0.5 millimeter. So what happens when you take a tooth out? What does the research show? So let's go to literature. The buccal contour change. Let's talk about this. Let's go to these famous articles that most of you quote if you're teaching. Some of you are teachers. I know that for sure. But you read these articles and you see these people getting up on the lecture circuit. Oh, when you take a tooth out, let's talk about Schwab. 5.9 millimeters of buccal lingual dimension change. When you take a tooth out in the posterior, that was the posteriors. Look at Lekovic and Kenny. In their controls of these 2 studies, they opened the flap. You want to see what happens? What happens to 6 anterior teeth? If you open the flap, debride it, take out the teeth, 6 anteriors, maxillary, and then primary closure. Without a membrane, that's what happens. Did it twice. You don't have to do it again. Over 4.5 millimeters of buccal lingual dimension change. What's the good news? The vertical distance of the ridge was not mostly changed in all these studies. Why? Because the palatal bone holds the crest up, but the buccal goes way in. So the ridge itself only went down a millimeter. You can live with a millimeter. You know, it's not the worst thing in the world. Although in New York, that's a lawsuit. I don't know about where you practice, but that's a lawsuit. No, but seriously, 1 millimeter you can deal with, but not 4, that's for sure. And so what we're dealing with here is a 4 millimeter buccal lingual dimension change if you open a flap and just close it. That's unacceptable. Obviously, we have to do something else. Now, so when we look at these numbers, they're not encouraging. I went back and looked at the literature on these, and what did they all do? Open flaps. They all open flaps to take the teeth out, whether it be in the molars or the anteriors. So now I ask you, my fine friends, my colleagues, here we are in 2013 talking about an extraction socket, which is the first thing that a dentist ever did, or anybody that tried to be a dentist, was take teeth out. 5,000 years ago, they were taking teeth out. And now I'm asking you in 2013, what dimension change will I do if I take your tooth out, that the buccal plate's there, and I don't open a flap? How much dimension change can we expect on the ridge? What data do we have? So little, it's frightening. What we have data on is with the opening flaps, and then going back 6 months later and opening it again. The number of 1 millimeter is going to come up. As Vera did this, Brownfield did this, and you'll see our research today. Uli Grunder in his control study, when he did connective tissue graft versus just a healing abutment, he showed a millimeter change. 1 millimeter is what we're kind of going to. That's without a bone graft, no temporary or anything. So let's take a look at this number. So here, it's not 4 and 5. 1 millimeter you can usually live with, and you probably won't even see it. More than that, get to 2 or more, you'll start to see some, black hollow shape. So I need you to understand that all these articles are flawed. I mean, they're okay if you want to see what happens when you open a flap, but no more flaps. So everybody raise their right hand. I promise. Never to open a flap again. Would you want me to open a flap on you if you just broke your tooth in my office? You came into my office? Huh? Come on. Who'd want me to open a flap on them to take their tooth out, even if I broke the root tip off? Anybody? All ears, I can see you here. No, of course you wouldn't. You wouldn't even think about it. Minimally invasive surgery is the name of the game. Just with our cardiac, look what they're doing now with cardiac work. They're doing heart valves through catheters now, endoscopic surgery. We could certainly figure out how to get a tooth out, even if it's fractured, even if it's just a root tip. We just have to change the way we operate our minds and and maybe some different instruments. There are great instruments out there. Go see Salvin and those other corporations out there. Go get these hybrids that they're talking about, little elevators to get root tips out. Get the deep grippers with tips that can grab. Please shut your phones off. These are the things. So don't do to others what you wouldn't want me to do to you. You wouldn't want me to open a flap ever on you if I didn't have to, because there's no swelling that way. My patients don't have swelling if I don't do that. If I open a flap, of course they'll have swelling. So let's go. So let's do a type 1 defect. You ready? So but this is the first thing, is selection of the case, not a type 2 defect. If it's more than 5 millimeters away from the free gingiva, the buccal plate, if 3 or 4 is normal. If you get to 5 or more, I call it a type 2 case. In the aesthetic zone, no way that I'm putting the implant in. Doesn't mean you can't do it. Doesn't mean you won't see people do it on the lecture circuit for the past 2 days. But is it predictable on a 100% basis? Not even close. So maybe 9 out of 10 times it is done, especially these guys that you see up here and women doing great work, but they're the best in the world. And you are too. But you know something? The body doesn't, you're asking the body to do too many miracles at once. Do one miracle at a time. You know, I've been said that. And David Garber's been quoted for what? Saying, do all site development. If it's missing, do the site development before you place the implant in the aesthetic zone. David, congratulations on that statement. You said it almost 20 years ago, and that still holds true today. But if everything's there, I'm going to want to leave it there. And that's the other thing. So let's take a look at this. This is a patient that comes in with external resorption. As you see here, high scallop tissue, thin. The one you want to send to your friend down the block, the one you don't really like that much. Because look, you have this resorption. Now, this is not endo versus implants. That's ridiculous. There's no controversy. Endodontists have an incredibly high percentage of apical fill. It's what's left of the tooth and what you have to do to destroy the tooth in order to get what you need. So in this case, we all talked about it, and we decided to take it out. We took the tooth out, and you see I did it as cleanly as possible. That's the way sockets should look when you take them out. Now, let's talk about placement. The placement we like in the aesthetic zone, in the 6 anterior teeth, we like to go towards the palate. We like to aim so that we can do a screw-down provisional, because we find that when we do the screw-down provisional, as you will see, there's no cement to worry about during the healing process. And we can sculpt the tissue any shape that we want, as you'll see in a moment. So we go towards the cingulum as my guide. And sometimes you hit the palatal wall and you get pushed a little forward. So we always start at the cingulum. You should never constantly be coming out the buccal. If you're getting a case, if you're not the surgeon doing your own case, if you're giving people, or if you're the periodontist oral surgeon and you're constantly giving people, or restorative dentist in the room, you're constantly getting a tooth coming out the buccal surface of these teeth, speak to your oral surgeon or periodontist friend and let him or her change. If they don't change, you get another oral surgeon or another periodontist. You got it? You should not be getting teeth coming out the midfacial tissue when you have everything here like this. You go up the palatal wall, and this is what it looks like. You then Steve will go through the temporization with you a bit, but you put on the PEEK material, or every company has their own a temporary cylinder. You have a shell made, and Steve will go through this with you. And this is what you put in. Supporting the tissue, normal contour of the adjacent teeth. Now, that's not a piece of junk. That's not some piece of garbage. But every dentist should be able to do that. This is not just for the top specialists like Steve Chu doing the prosthetics in this case. You understand? This is a single tooth. This is not full mouth rehabilitation. It's just knowing how to do acrylic and dealing with it. And Steve will go through that. And this is what it looks like at day 1. This one we didn't even graft the gap. We'll get to that in a few minutes. But take a look at this. At 4 weeks, wait a second, it's 4 weeks. Did we just get lucky? How about a little later? Let's get some extra healing. Here's 13 weeks. Do you see any problems? No. Now, I know what you're saying. Oh, these guys just got lucky on one good case, so he's showing the good case, huh? Isn't that what you're thinking? Some of you are. No? You're thinking it, aren't you? The truth. Oh, he's got one good case. We have dozens and dozens and dozens of these. And what we'll show you today is how predictable this can be. Now, you notice there's also bleeding when we take this out. And notice the tissue contour is not collapsed. In fact, this one, when we measured this, was only about a 1/2 millimeter when we finished the case versus the contralateral tooth. 1/2 millimeter. You can't see it. 1/2 millimeter is not in your visible line, but in measurement you can. And when we see bleeding, we like that. Why? You see bleeding when you take off a healing abutment sometimes? The first time you take off a healing abutment. Do you ever see bleeding? I don't care what system you use. Of course you do. What are you getting? What are you looking at? Even though the tissue was perfectly healed. Look at this beautiful tissue. The tissue is perfectly healed up there. See? What you're seeing is the epithelial attachment is on the abutment. In this case, it's not an abutment. In this case, it's a temporary. Can epithelium adhere to acrylic? Say yes. Yes. Epithelium can adhere to any clean surface, including titanium, including acrylic, including porcelain, including zirconium. Got that? So we're going to try and capture that during this initial healing because it keeps the tissue more coronal and thicker, as you will see. And Steve will go through the thickness part. Then he takes a customized impression, and here's the final crown. And you don't see this big concavity that everybody keeps talking about. And this one was without even a gap, without any bone graft. And so we have normal bone level, and this one didn't even have a platform switch because I was at least 1.5 millimeters away from all the adjacent teeth, which I'll show you before we finish today. So look, you don't see any bad contour. This looks great. The patient's happy, and so are we. So let's take a look at this case. Another high smile line. This case has a little thicker, flatter tissue, so it's a little bit easier kind of case than the first one I just showed you. But I want to show you what we're doing today. It's a good case to show you step by step, and Steve will take you again through part of this. But you see the cracked tooth here. The tooth comes out. Now, do I take it out first? See these beaks? These are like deep grippers. Titan puts them out. Salvin Corporation in the back has them. Go grab. You shouldn't be using 150s and 151s anymore. Those are for horses, okay? We're dealing with thin buccal plates. We want to preserve it, and this is what we use. We grab it on the buccal lingual, and they should have these little beaks that can go into the ligament a little bit and rotate. Now, how do you rotate a tooth out? How do you take a tooth out? You do not go, the way I was taught, okay, put the forceps on the tooth, assuming the crown is still there. You go buccal lingual, buccal lingual, buccal lingual, right? And the tooth comes out. Or you hear a crack. And that's either the buccal plate or what? Or the tooth. So that's as simple as that. That buccal lingual stuff's got to stop, other than the most minor amount. It's rotate and out, rotate and out. And we trisect molars. There are two burrs on every one of my extraction sockets that I do. I have a very thin tapered diamond to go down ligament spaces, almost like a peritome, to create purchase points for some of these new hybrid extraction forceps or elevators. And I can divide the teeth with a high-speed fissure burr, like a molars, trisect the uppers and hemisect the lowers. And so these are what we take out. We no longer put a forceps on a molar until we trisect it or bisect it. So here's the implant end. So the rule of thumb is what? 3 millimeters up from the free gingival margin and 2 millimeters back. So from the free gingival margin, 3 millimeters up is really about at the buccal plate, 3 to 4 millimeters. That'll give us running room on the buccal. And we place it 2 millimeters back, which is towards the cingulum. Then the Cooper calls it a 3-2 concept, but it's really just a cingulum. So it's 3 millimeters up. We've been doing this for years, and 2 millimeters back. That'll get you to do a screw down provisional, even if the final restoration will be cementable. We'd like the provisional to at least be a screw down, no cement. Now, in this case, there's a gap. So Steve added this, and he'll go through this with you to show you how to get this. So again, it's not a piece of garbage. This is well thought out, supporting the tissue properly of what came out. And smooth profile, no ridges and no bumps, and he'll show you that. But I need you to see this. Now, after he does that, I'm going to take it off. He's finished. I'm going to take it off. You could leave it that way, but I'm going to take it off, and I want to graft this one, as you'll see why. So I put a straight cylinder on, as you see here. I put a straight cylinder on and pack the bone. In this case, I use small particle mineralized bone graft. I put that in, pack it in, and then I take off the excess. Now, I have the temporary all ready to go. I basically squeeze it up, and all the excess comes out. Now, you notice what I did here, and here's a new concept that I want you to look at. The reason I show you this case, I didn't just fill up to the crest, did I? I filled the bone graft all the way up to the height of tissue. As I had some extra bone graft, I said, let me play with this, see what happens. And I came up with something I think you'll see that might be interesting. So I'm filled right up to the height of tissue. Then I squeeze it out with the crown that's already done. I take it out, and I squeeze it right up and take the excess off. So the patient walks out looking like this. That's the day of extraction. Got it? That's the day of extraction. Let's see what happens. Here it is at 1 week. I got lucky again, didn't I? We got lucky again. I'll show you how lucky we are. I got lucky this morning. That's why I won in craps. See? I'm a lucky guy. But seriously, this is unbelievable. You don't see 4 and 5 millimeters change because it doesn't happen. Why? No flap, no flap, no flap. If I'm on any tirade around the world in my lectures, it's just don't flap. You'll help yourself immensely no matter what else you do. Stop the flaps, even if you break root tips off. Learn to go through the opening. It's wide open. Just need the different instruments. Go get them. They're sitting out there. One-time commitment of these smaller elevators, hybrid elevators. Go get them, and then you have them. And a thin tapered diamond stone, and you're all set. Here it is at 2 months. Look how beautifully it's holding. You see the beautiful tissue. This one was only 0.2 of a millimeter, less. First case without a graft was about 0.5. This one is even less, 0.2 with the graft and a temporary. So we really, here it is at 4 months. Look how close you are. You're sitting on the guy's nose looking up into his mouth. You can't get closer than this. Do you see any major change? No, minimal to none. Nothing that you would see from a normal discussion. So like Uli Grunder talks about this depression and everything. That can happen for sure if you don't have a buccal plate or if you traumatically take a tooth out. And then look at the beautiful tissue response. Look at the scope of the tissue. That's got everything you need. And if you take the time to do this at the time of extraction and keep the tissue open, your work is done as a restorative dentist. By doing either a customized abutment or the provisional itself out of occlusion, you now have done what? All these temps are out of occlusion for 2 months until integration takes place. But what you've done is you've secured the shape. You don't have to start putting pressure on and shoving acrylic up there and doing pressure. It takes time. It takes more visits. It takes anesthesia sometimes and more visits for the patient and yourself. You're wasting a half-hour visits every time you see that patient just to scope the tissue back to what you had at the time of extraction. So use that time now, and then you don't have to do anything except take an impression. You're done. The tissue's sculpted, and this is the way you should be doing. And there's the implant, and there's the beautiful tissue, the little response. And then Steve did his crown, and he'll go through these things with you. And there's the final case. Another lucky case, I guess we got, huh? No, this is what we're doing. And if this hurt us, do you think we're stupid? In New York City, do you think we're crazy? We wouldn't be doing this routinely on type 1 defects if it hurt us. We have not gotten hurt by doing this. Not once. Not if you pick the right case and do just what I showed you. Simple, easy, predictable. Just pick the right case. Don't push it when there's no buccal plate. No buccal plate, no implant. Not that day. No buccal plate, no implant. No buccal plate, No implant. Okay, now you get coffee later. Okay, otherwise I'm going to block the door. I'm going to stand there and say, no buccal plate? No implant. Okay, you get coffee. Okay. All right, and you can see the beautiful tissue response. It's as if we did nothing. This one was even easier because it was thick, flat tissue. But the graft seems to help. It even did less contour change, as you'll see. So where are we with this today? We're going to move this through quickly. I came up with this concept I call dual zone socket management. There's the bone zone and the tissue zone. We always used to talk about the bone zone. And everything in the socket above the tissue zone is above the crest is tissue zone. Everything below is not. So what you see here, Steve and I and Maurice and Henry published this with Hanai Saito and Guido Saracano, and we got a case in there, so you'll see this concept. Now here's the new research that I want to share from our multi-center study along with the Garba Salama group and Goldstein group, and you see also from Guido Sanacchiaro down in Argentina. So to get enough N value. And what we did was we measured 7 reference points, 9 millimeters up from the contralateral side. 4 treatment groups. Let's go through them quickly. The 4 treatment groups are as follows. No graft, no provisional. Just put the implant in and a provisional and a healing abutment. That's what Uli Grunda did and his control on his connective tissue graft control, and he showed 1 millimeter change. We'll get to our result in a second. Group 2, no graft, but a provisional, like the first case I showed you. No graft in the gap, but provisional. Group 3, a graft with only a healing abutment, as you see here, but with the graft. Okay? And group 4, the graft and the provisional. Grafted and the provisional. Yeah, all guns going. Okay? So let's see what happens with our results with the buccal contour change versus the contralateral tooth. So we did our measurements in 7 places, 9 millimeters up. Now take a look with just the control. What you see here, 0.4, 0.8, 1.2 at 2 millimeters up, 3 millimeters up 1. So this is very similar. The one is almost identical to what Uli Grunda showed. And same thing with Vera's article. So we're starting to see a consensus of different articles showing that the buccolingual dimension change, I asked you a question earlier. What dimension change if you don't open a flap has been registered? It's probably about 1 millimeter with nothing except an implant and just a healing abutment. So what you see here is that it's no bigger than 1.1, 1.2. It's not 4s. So even that's not bad. Now let's look at group 2 with the provisional. It starts to get better. Look at this. It starts to get better. 0.7, 0.7, under 1 for sure. Now if we start putting grafts in, take a look at what happens. The grafts seem to minimize it. 0.3, 0.4, 0.4. This is not 3 millimeters, that's 0.3 millimeters. And when we did all of it, let's look at the whole ball of wax. We did all 4 things together. What do you see here? A 0. A 0. I like that. Our averages are less than half a millimeter, less than 4/4 of a millimeter all the way along. So graft plus the provisional to support the tissue seems to be, in our hands, the way to go. So we're grafting it to help support it. And the tissue thickness is also very important. Steve's going to go right into that, into this free gingiva thickness and the research on that. So the bone zone variables have been pretty common. Everybody knows them. But now we're starting to talk about soft tissue, aren't we? The color and texture of the abutment, the contour used, the number of abutment changes, as Henry says, 1 abutment 1 time, ripping that junctional epithelium. These are all the things that we're looking at now. And this is all new in the past nearly 5 years, that this is all blowing everybody away. And the last is what type of bone graft to use, xenograft, allograft. I'll just show you this case as a cautionary thing, because you take a look at this case, Philip had a fractured tooth. We're going to take it out. I take it out and without a flap, place the graft as you see here. And then we did the same temporary, all the same things I just showed you. The graft is in place. And now watch what happens at 4 months. Now, everything looks great. It looks beautiful. But take a look at 4 months. When Steve took this temp off, look what he sees. Whoa, by putting the graft up into the height of tissue, we're starting to see that we have what? Some particles didn't work their way out because they were caught because the epithelium was adhered to the temporary. So some of the particles, when you're using non-resorbable material, non-resorbable graft material, like a xenograft like this, it may plump it out, but it has a dual-ended problem. Maybe it can't get out. Now, I told Steve not to touch it. He said, should I just take it out? He said, no, let nature just do what it wants to. Now, let it exfoliate on its own because we don't want to create a big void. We want it to slowly work its way out. Now, don't you look right there. You don't even see it, but that's that piece right there. See it? Do you see that? Do you see this little piece right there? That's that piece. So it is trying to work out slowly. Let's just as Steve, keep going. Do your beautiful crown. Do everything. Here's the crown. But look at it. 5 months, 6 months. At 8 months, you see it's starting to go away. Have we lost a little depression? Maybe. But it's hard to say. We need to look at this at 2 years not just 6 months. At 6 months, these are great. And so the crown is in and looks great. But that's, you see, there's the pre-op and there's the post-op. It's as if we did nothing. But we know that there might be a decrease over time. We're not sure. And it works out well. And the last is the peri-implant soft tissue. I'll talk about for a moment biologic width. And we do like biologic width implants that have platform switching. Why? This is the normal zone of irritation when you don't do a platform switch. Based on my research in 2000 that I published about papilla, we know that the horizontal component of the biologic width is about 1.4 to 1.5 millimeters. And it's all the way around. So you put a regular non-platform switch implant in, you better be 1.5 millimeters away from all vital structures, adjacent teeth, adjacent implants, and the buccal plate, as I was in the first case. But if you take a look at this, what happens if you if you get too close, more than 1.5 millimeters, you'll lose the bone on the adjacent tooth. You could also go too far buccal, which is the worst place to come out, and that'll knock out your buccal plate and cause recession, besides being difficult to restore. So let's take the same zone, and what happens if we put a platform switch implant like you see here? Watch this carefully now. This is the greatest slides. This is where computers are great. That 1.5 millimeters with the same diameter implant, the zone of irritation will shrink in to about 0.5, give or take a tenth. And that's what we see now, which means you have extra freedom on the sides and extra freedom on the buccal not to cause an injury. So where's the future? The last slide I have here is displacing a graft into the gap, keep tissue height and width long term. We see our data is at 6 months. We now have to go out 2 years and 5 years. Does it still make a difference? Does platform switching aid in preventing recession by thickening the tissue, giving you more room? We think it does. Does placing a full contour provisional or custom healing abutment allow for better mid-facial contours? Our data says it does. Does removing the abutment multiple times affect tissue height and width? Still unknown. We're still not sure about this. It makes sense clinically, but we're not sure if it makes too much difference clinically. Histologically, it makes difference, but maybe not clinically, except between 2 implants when you want to regrow a papilla. What significance does the abutment texture and color have on aesthetics? And should the bone graft be absorbable or non-absorbable? But I think I've given you a premise. And Steve's going to take over for the aesthetic part now and the color and dimension. But I think I've given you a premise to do what? No more flaps, graft the gap because it helps keep the tissue ridge shape better, and provisionally custom abutment or full provisional without occlusion during the healing phase. I thank you so much.